Welcome everyone, I'm Najla Nasri from Johns Hopkins and I'll be moderating the Journal Club session. Today we're fortunate to have Dr. Paul Bergl presenting his recent manuscript called Frequency of Diagnostic Errors and Related Risk Factors in the MICU, a retrospective cohort study. It'll be a great session, so thank you all for joining us. So we'll now transition to the presentation portion of the session. I'm pleased to introduce Dr. Paul Bergl, who is an assistant professor in critical care medicine at the Medical College of Wisconsin. He graduated medical school from the University of Wisconsin-Madison and completed his residency and chief year at the University of Chicago. He previously served as assistant professor in general internal medicine at the Medical College of Wisconsin and completed a one-year fellowship in medical education and a one-year fellowship as well in diagnostic medicine through SIDM. As a clinician-educator, his scholarly interests include teaching and assessing diagnostic reasoning, identifying and understanding the causes of diagnostic error in the ICU, and promoting bedside rounding and teaching. Welcome, Dr. Bergl, and thank you for presenting today. We'll now turn it over to you.
Excellent. Thank you very much for allowing me to host this journal club. As Najla pointed out, I'm going to be discussing my research, the frequency of diagnostic errors and related risk factors in the medical ICU, a retrospective cohort study. I do want to start out by apologizing. I know it's not typical to do a journal club without an actual journal article. I want to accept this invitation just over a month ago. This article has been accepted, but is not yet in press. So you'll see the full text of the study out very shortly in Critical Care Medicine. It's in production. So I guess I have to pay a little bit closer attention as I'm going through my slides here. I have no relevant disclosures or conflicts of interest. Dr. Hardeep Singh was a mentor and a co-author on this project, and he is supported as outlined here. So first, let's talk about the safety of critically ill patients more generally as a backdrop to our discussion of diagnostic error in the ICU. And we know that the safety of critically ill patients is actually often in jeopardy. So 20 to 40% of ICU patients experience at least one adverse safety event during their ICU stay. And many of you may have seen this recent meta-analysis in the British Medical Journal of preventable adverse events. Amongst all care settings, the intensive care unit is actually the highest risk setting, not surprisingly. ICU patients have the highest prevalence of preventable adverse events, up to 26% in the studies. There are obviously myriad reasons for this. Some of the factors contributing to the risks of adverse events in the ICU and diagnostic error in particular include the following. We have vulnerable patients. Not only are they sick and quite ill, but they're often unable to provide a history, which is clearly a critical part of establishing an accurate diagnosis. They're not able to fend for themselves or make decisions for themselves. The pace and the complexity of care is obviously at the highest level. We have countless data points that we're often generating, trying to manage. Interruptions are frequent. Invasive procedures are commonplace. There's a lot of things that are happening in ICU that jeopardize safety. It's a busy environment. And then finally, handovers are a big part of really any contemporary medicine, but particularly in the ICU, as many ICUs have moved to a closed model of care, patients by necessity have to be handed over to another team. So what do we know about the scope of diagnostic error in the ICU specifically? Well, there have been a number of cohort studies, autopsy-based over the years, that have given us some insight. What we know from these studies, including some of the largest, most recent cohorts, is that there are major discrepancies between antemortem and postmortem diagnoses in nearly 1 in 6 cases. And a recent meta-analysis in 2012 in the British Medical Journal Quality Safety by Winters et al. Had a projected prevalence of Goldman Class 1 errors in the critically ill of 6.3%. So if you're not familiar with the Goldman classification of errors, it's class 1 errors are basically errors that likely contributed to the patient's death. And this was a projected prevalence. Actually, the rate of Goldman class 1 errors is higher in autopsy cohorts, but Winters et al. Did an estimated prevalence based on if everybody who died in the ICU were to be autopsied. So it was actually even more frequent than that these types of errors were found. We know from some contemporary studies in critically ill patients, critical care safety studies, that diagnostic errors are implicated in 9 to 62% of unplanned ICU admissions. And in one study, the physician reviewers found that nearly 90% of those diagnostic errors were considered preventable. There was a really nice cohort study done a couple of years ago, published in Pediatric Critical Care Medicine, that found that diagnostic errors were quite common in high-risk pediatric ICU patients, with a rate that approached 30% in the highest risk patients. These were patients that ultimately required invasive mechanical ventilation or vasopressors. So the sickest pediatric ICU patients had a prevalence of 30% diagnostic errors. Now, we felt like there are a few holes in the literature here, though. So with the autopsy studies, there obviously are some limitations. The major limitation being that they're limited by referral bias. So we are obviously only autopsying patients who are interesting in some way. And we're also excluding survivors of critical illness who may still have been victims of diagnostic error and the consequences thereof that aren't being captured in these studies. Further, autopsy studies are largely descriptive. They are not often clarifying the mechanisms leading to diagnostic error or the risk factors for diagnostic error. They're just describing how often they're happening. As I said, there have been other contemporary safety studies in the ICU that have included a classification or a category for diagnostic errors, but those studies have not used some of the more robust frameworks or definitions that this community is using nowadays to define a diagnostic error. And they're focused on broader safety issues and maybe are perhaps a little too broad and haven't focused specifically on the diagnostic process. And of course, this pediatric literature is great, but I work in the adult world and I want to know what about the adults in the ICU. So we sought to conduct a retrospective cohort study that had these three primary aims. First, we wanted to determine the frequency of diagnostic errors in patients admitted to the adult medical ICU. We wanted to measure how often these errors are present and recognized within the first 24 hours of care. As many of you recognize, many critical illness syndromes are very time sensitive, and recognition of what's driving that is really time dependent in many scenarios. Sepsis, acute pulmonary embolism, myocardial infarction, all of these things require timely recognition, very timely recognition. And finally, we wanted to examine potential risk factors and contributing causes to these errors. So as for our methods, we conducted, this is a broad overview here, we conducted a retrospective cohort study using chart review. These were non-surgical medical ICU patients who had admissions between July 2015 and June 2016, so over a 12-month span. We looked at unplanned admissions, which in a medical ICU is almost every single person that's admitted to the ICU. So unlike a surgical ICU where patients are often admitted postoperatively after a coronary bypass or transplant or something like that, we look, in a medical ICU, we're really just getting unplanned admissions from the emergency room and the ward. And we collected detailed physiologic, demographic, and clinical data to try to ascertain some of the risk factors for diagnostic error in our group. A little bit about the setting where I practice. It's a 26-bed medical ICU. At the time of the study, it was a 536-bed academic tertiary care hospital. We have two academic teams consisting of an attending physician, a fellow, various residents of different disciplines, and advanced practitioners. The average team census for each of these teams is between 13 and 14 patients. So as you can see, that math doesn't work out. We're often spilling out of the main medical ICU and taking care of patients in other ICUs as well. And we do not have in-house overnight attending physician coverage. So typically between the hours of about 5 or 6 in the afternoon till 7 the next morning, there is not an attending physician providing direct oversight. As for our subjects, so as I said, it was over a 12-month period. During that 12-month period, we had over 2,100 admissions to the medical ICU patient, 2,100 patients admitted to the medical ICU service. We sequentially randomized those charts, and then we sequentially pulled them and ended up manually screening 434 charts total. We excluded patients for the following reasons. First, whether an investigator had cared for the patient within the 48 hours of initial ICU admission. We thought that there would be a lot of bias introduced if the investigators were reviewing their own charts. We excluded outside hospital transfers primarily because there was not enough clinical data to review those patients, we didn't feel. Some patients got incorrectly assigned to the team, so they were screened by the electronic screening method as being in the medical ICU service when they actually weren't. And then several were actually just planned admissions for primarily for medication desensitization, allergies to aspirin or things like that. So we ultimately conducted a detailed analysis of 256 charts. In terms of how we define diagnostic error, we use the SaferDx framework. So the case analysis had to reveal evidence of a missed opportunity to make a correct or timely diagnosis. That missed opportunity was framed within the context of an evolving diagnostic process, and the opportunity could have been missed by the provider, the care team, the system, and or the patient. We use this, a modified version of the SaferDx. We made a few changes to this that I think are important to review. I know many of you are familiar with this instrument. It's a 12 or 13 item tool that can help ascertain whether diagnostic error occurred. Some of the wording, though, we felt was not appropriate to the ICU population, so we tweaked some of the language. We also felt like it was a little bit long to complete, so we took the 6 items in this instrument that had previously been shown to have the highest predictive value for diagnostic error. At the end of using the tool, each reviewer ended up answering these 2 big questions. First was a final judgment overall, whether or not there was evidence for diagnostic error. on a scale of 1 to 6, as you see here. And then we also judged the consequences of the diagnostic error if the rating was greater than 3 on the previous item. So if error was felt to at least be somewhat likely, we then tried to judge the consequences of that error. Again, on a similar 1 to 6 scale, this type of scale is used in other safety literature as well. So we used a tiered approach to chart review. First, I was the primary investigator, so I screened the initial charts. This was done while I was a critical care fellow. That was a manual screening of the charts to make sure all inclusion criteria were met. And then I conducted the initial detailed chart review using the SaferDx and completed the SaferDx instrument by myself. If the ultimate judgment by me as the primary investigator was that it was a low probability of error, it was not sent on for further review. But any chart that was generated a moderate probability of error, so on a scale of 1 to 6, a 3 or higher, it was sent to 1 or 2 faculty intensivists, each of whom had 7 or more years of practice. So this schematic probably helps make that a little bit more clear. So again, there was an initial review by me as the primary investigator. If it was a low probability of error, 2 or lower, then we did not do additional review. If it was a high probability of error, it was reviewed by at least 1 additional investigator who was a faculty intensivist. And if that reviewer felt it was also high probability, we felt like that was establishment of a diagnostic error. For the intermediate probability cases, though, all 3 reviewers reviewed the case. And then ultimately, we discussed all of these in a team meeting, both the ones that were of intermediate probability and high probability, to make an ultimate agreement. So that's how we arrived at adjudication of diagnostic error. And then once we adjudicated all the diagnostic errors, we divided the cohort into 2 categories, basically those that had experienced a diagnostic error and those that hadn't. We conducted descriptive analyses on the patients using students' t-tests for continuous variables and Pearson's chi-squared for categorical. And then we also developed a multivariable model using logistic regression analysis to try to, again, determine what specific risk factors independently predicted diagnostic error. So as for our results, we found a total of 18 diagnostic errors. So 18 admissions were associated with diagnostic errors of the 256 patients, which works out to 7% of the cohort. On the initial review by me, 88% were deemed to have low probability of error and were not, did not undergo secondary review. Of the 18 admissions with diagnostic error, all errors were present upon admission to the ICU, and only 6 of these were recognized within the first 24 hours of care by the ICU team. And all admissions were associated with all the diagnostic errors were associated with some degree of harm, and 6 were actually a quite substantial harm, which I'll show in a little bit later. In terms of looking at the descriptive analysis, we found that female gender was significantly associated with a likelihood of diagnostic error. So was the whether or not the patient was discharged from the ICU within 24 hours. So the significant number of patients, sorry, let me rephrase that. On the next slide, I'll rephrase that a little bit better. Q-SOFA score was predictive as well. So this is a severity of illness score in ICU patients, initially used for sepsis, but also has been validated across all critical illness syndromes. A Q-SOFA score of 2 or higher was associated with a greater likelihood of diagnostic error. And then Apache 2, which is a more detailed severity of illness score, which incorporates a number of physiologic variables, was also predictive ultimately of diagnostic error. So I just want to rephrase the 2 of those things from the previous slide and rephrase them in a little bit more digestible way. So with respect to female gender or sex, I'll use the 2 interchangeably because at the time, our electronic health record only had a field for sex, not for gender identity. So we are just using the sex data field in our electronic health record as male or female. So for those women, they were more likely than men to experience a diagnostic error. And as you can see, there's a big difference percentage-wise. So almost 12% of the women in the cohort experienced a diagnostic error, whereas fewer than 3% of men experienced a diagnostic error. Similarly, if we look at patients who were discharged from the ICU within 24 hours, patients discharged from the ICU within 24 hours experienced significantly fewer diagnostic errors compared to those who had longer ICU stays. So amongst those discharged promptly, only about 3% of them had diagnostic errors, again, whereas those who lingered for more than a day, 11% of them had diagnostic errors. After we adjudicated diagnostic errors, I went back and used the DEAR taxonomy to classify the different types of diagnostic failures that were present. I know many of you are familiar with this way of classifying diagnostic failures in the diagnostic process, and these were the most common errors that occurred. Too much weight on competing diagnoses was 100% of the cases. Failure or delay in considering the diagnosis was the majority of the cases. too little consideration given to the ultimate diagnosis, and failure in weighting the history. So obviously a lot went into history and diagnostic prioritization. When we developed a multivariable logistic regression analysis, we found that really only 2 variables independently predicted risk for diagnostic error. One, again, was female sex. It was independently associated with risk both at admission with an odds ratio of greater than 5, as well as at 24 hours with the odds ratio going even higher. So women were at substantial risk for delayed recognition of their diagnostic errors. And the Q-SOFA score, again, remained independently associated with diagnostic error, again, with a pretty high odds ratio. And the variables that go into that, for those of you that don't deal with this on a daily basis, are pretty simple. Bedside metrics of critical illness, whether or not a patient has altered mental status as defined by Glasgow Coma score, less than or equal to 14, whether or not they're hypotensive as defined by their systolic blood pressure, and the respiratory rate being greater than or equal to 22. So those simple predictors of critical illness severity also were predictors of diagnostic error. Variables that were not independently associated with diagnostic errors, which we were somewhat surprised by, and so were our reviewers, are the following. So the age of the patient had no impact on whether or not they experienced diagnostic errors, whether or not the admission occurred during the nighttime when fellows and residents are relatively unsupervised and there's no attending physician in the house, that had no impact on diagnostic errors. The number of consulting teams involved did not have an impact. The race or ethnicity of the patient, the presence or absence of altered mental status, and then whether or not the admission came from the emergency room versus a ward had no impact on diagnostic errors. So as for our discussion, these are the big take-home points. Obviously, who is at highest risk of diagnostic error in the ICU? At least what we found in this cohort, clearly women, and those odds ratio are pretty robust. Patients with higher severity of illness scores, and then patients who stayed in the ICU longer than 24 hours. And I'd say that these latter 2 things probably go hand in hand. Those that are lower severity of illness end up probably with a shorter ICU stay than those that have multiple markers of severity of illness who will stay longer. So that's probably why this ICU duration ended up shaking out as being not independently associated, I think, because it ends up being captured in the severity of illness overall. So what are the implications of these findings? Well, we actually have a lot of ICU admissions in our country every year. These are US data, 6 million ICU admissions every year. So 7%, while it may seem somewhat inconsequential, if you extrapolate that over a population, that's 400,000 ICU patients each year in the US who may be victims of diagnostic error. And if we assume that 5 to 10% of these errors are fatal, and in this cohort we found that 2 of the 18 were directly involved in the patient's death, that would ultimately account for 20,000 to 40,000 deaths in US ICUs annually from diagnostic errors. And that estimate actually aligns with the estimates that came from the 2012 meta-analysis of autopsy studies, which would have predicted a similar number of deaths in ICUs every year due to diagnostic error. So it's this is a pretty good estimate, I think, of the burden of this in the United States. So in general, the frequency has been found to be a little bit higher in ICU cohorts. We saw in the pediatric population up to 30% in high-risk patients. In autopsy cohorts, maybe closer to 20%. So why is our frequency of diagnostic error on the lower end? I think there are a few good reasons. First, I think is just our approach to how we screen charts. So we had this tiered approach that prioritized specificity over sensitivity. So we referred cases of modest probability, but we did not have all of the lower probability cases reviewed, and even a handful of those could have, substantially increased our prevalence of diagnostic error if secondary reviewers had found those to be cases of diagnostic errors. Obviously, any retrospective chart review relies on clinician documentation, but I think particularly relevant is in the ICU population is that many steps of the diagnostic process often occur before a physician even has time to document their thought process. So this reliance on clinician documentation becomes even more relevant perhaps in retrospective core studies in the ICU. Our patients in our ICU, perhaps due to local culture or practice, tend to be a little bit lower acuity when we compare them to other US ICUs nationally. So when we look at the Apache 2 scores in this cohort of patients, they predict a 15% mortality of ICU mortality. But when you look at general Apache 2 scores across ICUs in the United States, those scores tend to align with like a 25% predicted mortality. So just the acuity of our patients in the ICU perhaps is a little bit lower, which may account for why there's a little bit lower frequency of diagnostic errors in our cohort. And finally, this approach prioritizes errors of omission, but does not capture what I'll call over triaging. And this is a term that actually appears in the literature a bit as well. And something that one of our reviewers really harped on is that, this approach captures the misdiagnoses, delayed diagnoses, but there's really no quote unquote penalty for the patients that are sent to the ICU who actually didn't need to be there, in which, maybe that's a form of diagnostic error as well. We could perhaps talk about that in discussion. So why is there a big gender gap? I just wanted to talk about this a little bit. These are what we found, but I'm looking forward to discussing this with everybody in the audience today. I think the nature of diagnoses in this cohort may have something to do with it. So we have lots of sepsis in this cohort, and we know that there may be some sex and gender differences about how women present with sepsis that may account for some of that. Sex-related differences in disease prevention, so obviously may account for some of that. So we know that in sepsis, for example, women have different interleukin profiles compared to men, and they have different symptomatology. So that may be some of it, which may be that they respond to critical illness differently, and how they manifest disease is different, which may impair how we recognize some of these disease and syndromes in the ICU. It may just be that there are some systematic biases against critically ill women. This goes beyond diagnostic management or diagnostic reasoning, but into therapeutic management as well. So we know that critically ill women are less likely to receive dialysis, for example, compared to their males in some cohorts. So that may be some of it as well. And then just more systemic gender bias may be in play. I'm not entirely sure. So here are some of the limitations of this study. Obviously, it was a single site. There are some potential biases that come with reviewing your colleagues, which is essentially what we were doing in this study. On the one hand, there is hindsight bias, which we might be underestimating the rate of diagnostic errors. On the other hand, there's some halo effect in play where we're evaluating the diagnostic reasoning of some of our colleagues, and we might give them the benefit of the doubt when there's some doubt about whether or not a diagnostic error occurred. So both these biases may be in effect. We did modify the SaferDx tool, and we have not externally validated our modified version of that, nor have we replicated that elsewhere. So that's another problem, of course. And then we did exclude outside hospital transfers, which are commonly viewed as a potential trigger for diagnostic uncertainty. Patients might come to a tertiary care hospital because the physicians at the other referring facility may not know what's going on with them, and there may be a need for additional diagnostic expertise. So it may be that excluding those patients actually reduce the prevalence or incidence of diagnostic error in this cohort, but we obviously had to exclude them, we thought, because we just didn't have the clinical data to review. So I want to thank everybody involved here. This is the study team. Rahul Nanchal is my local senior mentor. Amit Taneja is our other intensivist who reviewed the charts with us. Dr. Hardeep Singh and Rob Elkaray, who are both mentors and co-authors in this project and mentors through SIDM. I want to thank the SIDM Fellowship for mentoring me through this project, in particular Karen Cosby, who directed the SIDM Fellowship, and then just the general SIDM community for not only inviting me to talk today, but providing a forum for this type of research and an interested audience. So thank you all, and I'll open it up for discussion.
Great, thank you, Dr. Bergl. That was great. So we'll open up the floor now for any questions or comments, and you can feel free to unmute your mic, or if you'd like to post it, a question in the chat box, you can do that as well.
Hello, this is Ashley Meyer. I have a question for you. That was a really interesting presentation, Paul. You guys can hear me, right?
Yep.
Okay, just checking. So I was involved just for purposes of, what's the word, transparency, in the SaferDx instrument, the original and the revision that has come out recently. I was wondering, so the original validation of it has 11 questions, and all of those areas were shown to be significantly related to whether an error happened or not. And you said you wanted to make it shorter, so you used the 6 that were most related, which makes sense. But I'm wondering, so in the first study, those are actually all primary care cases. So it might actually be that in an ICU setting, different items would relate more to presence or absence of an error. So I wondered if you included those other 5, you might find different, well, you'd probably find more errors that you didn't catch. So your overall estimation of how many errors are occurring is probably, I would guess, an underestimation. And most are, since we are relying on documentation and things like that. But do you think that the types of errors you would find would be different in the ICU than, primary care setting.
I think so, and I think that's part of the reason we modified some of the language on some of the specific questions. And I have to go back and look at the items that we excluded. I printed out my manuscript, but I don't have the specific modifications being included. Honestly, when we looked at the correlation for each of the items in our study, which obviously was an even nearer number of questions, but there really only were two that were the most strongly associated with diagnostic error, and that was whether or not the red flag symptoms or signs were acted upon early enough, and whether or not the I have to look at it, whether or not the diagnosis was considered, whatever that item is on there. So it was really simplified to, at least in this cohort, even just two questions that were most strongly predictive. So your point is well taken. It's possible that we underestimated the rate because we excluded some of these other questions that we thought were going to be less predictive. I don't know, but it was interesting that in the end we found two that really had very strongly independently predicted in a multivariable logistic regression, and the other ones kind of were not as helpful.
Oh, interesting. Yeah, that's really interesting.
We have a question from the chat box, which is from Dr. Dan Mayer, who said, how can you improve the methods by which you studied this problem? What about blinding of reviewers to the purpose of the study?
So I think one of the things we're doing right now actually is trying to do some prospective data collection. So this past summer, we've been doing on the fly collecting of clinicians' responses to their diagnostic impressions, and not what goes in the chart, but what are they actually thinking. So I think that's hopefully going to obviate one of the big limitations of this type of study, which is when you're looking at charts, it's hard to know what exactly they're thinking, and you're making some inferences. You're often giving people the benefit of the doubt. As for the issue of blinding reviewers to the purpose of the study, I'm not sure how to best do that or what that would add to it. I think that we knew we were out to seek diagnostic errors, and we knew we had an instrument to try to do that. So I guess I'm not sure exactly what you mean by your question. Other question?
Yeah, Paul, I have a couple questions, and I was wondering if, when you did the analysis, if you found any sort of like temporal relationship with the time of the year, like were diagnostic errors more likely to happen in the summertime because the team taking care of the patients were more novice?
Excellent question. We did collect the admission date, but I don't think we ended up putting that into the model as an independent variable. So that is something we might want to go back and look at. I think we ended up having a pretty even spread across all 12 months. That was one concern that we had. We shared that same concern, but we actually didn't analyze it separately. So that's interesting, and I just don't have the answer.
One other question that I had was, just as far as different variables, is did you guys look at the length of stay? So for example, like if someone's been on the wards for a month, does a longer length of stay correlate more likely with a diagnostic error, because by the time they get to the ICU, the team has to shuffle through so much more data?
Also a great point, and no, we didn't. We just looked at source of admission, and we looked at a simple dichotomous variable as whether or not they spent more than 24 hours in the ICU, but we did not look at length of stay leading up to it. So points well taken.
We have another question from the chat box, which is, how does the failure to communicate the explanation of patient's problem, which is part of the IOM definition of diagnostic error, applied to this study? Were you able to review the communication with the patient or family prior to or during the ICU admission?
That's a great point. And we really had no way to do that through retrospective chart review type studies. So we're kind of trying to build toward that. I think, as I said, we're working on a study now that's prospectively collecting nurses, residents, and other physicians and diagnostic impressions in the ICU. And I think the next tier of that is going to be looking at how well families feel like the team is communicating with them and what their understanding of the diagnosis is. We just that's a big IRB hurdle, but that's the big hurdle to get through next. And we wanted to get a couple studies off the ground before we start to delve into that.
And then there's a response. This was just in response to the first comment too, from Dan Mayer, who says this is a difficult process, but getting chart reviewers who don't know why you're doing the study and are only asked to look for certain information, the info you're interested in, and other non-essential information. Then having two reviewers look at a subset of charts to determine inter-rater reliability until they're pretty much equal, and have them each review the balance of the charts. This method is found in Gilbert and Lostein, Annals of Internal Medicine from 1996. Is it right?
I think I see the point now. So I think the point is that if we did not disclose that this was ultimately to adjudicate diagnostic errors, but I had them fill out the instrument, someone blinded to a definition of diagnostic error, we could look at establishing inter-rater reliability on an instrument. I think that's the point Dr. Mayer's trying to make. And we didn't do that. I mean, that would be another take on this, I guess. Looking for ways to take this to the next level, and that would certainly be a way to refine the study.
Hey, Paul, this is Grant. So in our neonatal ICU, doing a similar type of study, one of the things that have come up is looking at the charts for after discharge, and some of the errors that we found have been post-discharge, things that were like in the chart but weren't necessarily available if you just looked at the time in the ICU. Is that something you guys looked at or considered when you were going through this?
Yeah, so the chart review is pretty comprehensive. I mean, it really looked from the moment they arrived in the hospital to the time they were discharged. And obviously the focus was on diagnostic errors around ICU admission. So we probably came across other errors that occurred outside of the context of the ICU, but our team decided we should not be counting those. We really just wanted to know what are the relevant diagnostic errors that the ICU team could have had a major impact on. So whether or not there were other secondary diagnoses that were perhaps missed, that was not the focus of this. And I'm sure that if we included those, then there probably again would be a higher rate of error. It just, is that impactful? I'm not sure. We perhaps intuitively or implicitly, we looked only at cases that ultimately had harm associated with them. So maybe that was part of our calculus for identifying these errors in the first place, is that they were not only the diagnoses that were not recognized properly, but then ultimately were complicated by some degree of patient harm. So I think that perhaps speaks to your point.
Great, and we have a response back from Dr. Mayer, who says, yes, thanks. And it could be done using the same charts and some novice reviewers. Best of luck with this. It's a challenge, but much cleaner. This is especially true since you're asking your reviewers to find diagnostic errors in colleagues' charts, something that's laden with potential for bias.
Oh, absolutely, and I think that's a huge limitation here. And I think that's something we've talked about, is having fellows or residents look at these with the instrument and seeing if they're able to pick up on this. And they're, even if they're not blinded to the whole purpose of it, they're at least in a somewhat different position. They're not, evaluating colleagues, which is a little bit precarious position to be in.
We have another question, which is, do you have any follow-up studies planned or any topics you'd like to explore in the future based on the findings from this study?
So I think, what we're interested in exploring are a few things. First, we would like to see the findings here replicated in the same way. I think the disproportionate way in which diagnostic errors affected women in this cohort would be interesting to see if that's something that occurs across other care settings, or particularly ICU, if there's something about the ICU that is biased against women. So that's one thing we'd like to follow up on and validate in his second cohort. One of the things we're really interested in is this idea of over triaging, which I discussed before. So, 7% of the patients in this cohort had a diagnostic error. In the family of diagnostic errors, we usually think of missed or delayed things that cause harm. But what about the patients that are brought to an intensive care unit, perhaps inappropriately, and then suffer acts of commission from invasive procedures or excessive fluid loading or whatever that is, that ended up being nothing. So I think that's another next step that we'd like to look at. And I think the last thing is what I already alluded to, which is trying to collect some clinician impressions prospectively and catch them off the chart and see how well teams agree, which obviously is something we've all been thinking about. You know, how do diagnostic teams function? Well, an ICU team is a big diagnostic team. So what is the rate of agreement amongst team members about what the leading diagnosis is? How accurate are teams when we're collecting this data prospectively, quote unquote, off the records, not in the chart? And to what extent are nurses clued into this? So they're obviously a huge part of our ICU team, and they provide 95% of the care of the ICU patient. So we're interested in looking at how well are nurses kept in the loop of what the leading diagnosis is and what is their level of understanding.
Right. And Dr. Mayer says, I'd suggest a senior medical students as a good source of reviewers. It'd be interesting to see if the blended reviewers, duplicate the results you found.
I think one of the simplest ways to measure diagnostic errors retrospectively, which I know a lot of you have done, is just looking at differences between admission and discharge diagnosis. And I'm not talking about even what's coded in ICD-9 or 10 codes or whatever, or orders that physicians place, but really in an assessment and plan prior to ICU admission and the discharge or transfer note from the ICU, what is the leading diagnosis? I think, yes, even a third or fourth year student can recognize those discrepancies and can potentially, complete an instrument like SaferDx, look at that type of thing and start to examine some of these errors. Any additional questions?
This is Grant again. I have one more question. And I might have missed it, sorry. When you guys were cohorting the info with the diagnostic errors, did you guys look at time of day when the error, which I know is difficult to ascertain from chart review, but did you guys try to look at pinpointing what time of day that you think at least the error originated in?
Well, we tried to by when they actually were admitted to the ICU. So we used arbitrary time cutoffs of 5 p.m. and 7 to 7 a.m. as being a night admission, and 7 a.m. to 5 p.m. because that's generally when attending physicians are in the ICU, or sometime between 7 a.m. and 5 p.m. every day, usually a little later, but we did want to try to separate that out in some way. So it's imperfect. A better way to do that obviously would be like time from ICU admission to when the attending physician evaluated them or something like that, but that's it's more difficult data to collect. It could be done, but we just did a simple dichotomous variable, night or day admission. And we found no difference, I should say. That ended up not being predictive of a diagnostic error. Okay, any other questions? If not, do we wrap it up, Nashla?
Yes, I think if we have no further questions or comments, we can close out the session. So thank you, Dr. Bergl and for you all for joining us today. Our next journal club is going to be held in October, and if there are any recommendations for future sessions, we'd love to hear from you. Otherwise, thank you very much, and enjoy the rest of your afternoon. Take care.
Thanks for all your participation, everyone. Thanks.
Thank you.